like I'm understanding it as it is.
Oh, that's good.
So I just have identifying the
Yeah, it's really good.
Okay, we're going to move today into the abdominal wall. And tomorrow we have 2 lectures scheduled. If it's okay with you, I'd like to do them back to back. The first lecture only has about 20 slides. The second one has 40-something slides, but a lot of those slides are just clinical issues, that illustrate a point. So, but if we can knock those out, then we can go on over to the lab and get that started. Well, I have to be over at the state medical board tomorrow at 3, so I'll be bugging out. Hopefully we can get a long way through the reception before then. Okay. So the abdominal wall, landmarks, if you look at the anterior abdominal wall and superimpose the viscera on there, you'll see that a large part of the intestines are actually within the boundaries of the ribs, the costal structure. The costal margin extends from here all the way up and back down in a V. If you put your hands right here on the points of your hips, those points are called the anterior superior iliac spines. If you trace, and put your hand on your pubic bone, the lateral margin of your pubic bone, or the ASIS to your pubic bone, is a structure we're going to talk about later on, called the inguinal ligament. The inguinal ligament runs from the ASIS to the pubic tubercle of the pubic bone. The umbilicus is important for several reasons. One is it divides the abdomen into upper and lower quadrants. You'll see in just a second. The second point that's important is that right there at the level of the umbilicus is where the abdominal aorta divides into the right and left common iliacs. So the iliacs, when you start doing physical exam, and you're listening for iliac bruits, they're not way down here, they're actually up here, pretty high. Anatomists like to divide the abdomen into 9 different sections, but clinically no one does that. They're divided into 4. Right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant. You need to know what's in these quadrants in order to develop a differential diagnosis. If somebody's complaining of left lower quadrant pain, I can promise you it's not gallbladder, which is right up here in the right upper quadrant pain. Right upper quadrant. So knowing the structures in these different quadrants is important, not only for the way patients present, but trauma that you're sure to have on this test. I always appreciated in the ER when somebody would come in complaining of, when a male would come in complaining of left lower quadrant pain, because the differential diagnosis is short. I hate it when a woman complains of left lower quadrant pain, because as you'll see when we get to the pelvis, in the 4th section, your pelvis is connected to your abdomen. So you have to add everything gynecologic to these lower quadrants. That's why I hate you. Because a lot of that stuff can kill you if you miss it. And so men are much nicer because it's most of the time it's going to be diverticulitis, and you send them on their way. Okay. The layers of the anterior abdominal wall, they take on different names than what we've seen so far. Starting from the outside, you've got the skin and the dermis, And here's the superficial fascia here. The superficial fascia of the abdomen has two different layers. It has a fatty layer called campers, and then it has a thin fascial layer called scarpas. And under scarpas would be the deep fascia of the outermost muscle, which is the external abdominal oblique. Okay, so Camper's fascia, being fat, if you can get a person who weighs, 300-400 pounds, that fatty layer can be, a foot thick or more. It can be quite impressively thick. On our cadavers downstairs, they're all pretty thin, so it's not going to be that thick. All right, so you have three layers of muscle that represent the abdominal wall out here. Not in the midline, but out here. There's the external abdominal oblique, the internal abdominal oblique, and then the deepest layer is called transversus abdominis. It's up here somewhere. There it is. Transversus abdominis. Now, deep to transversus abdominis, there's a tissue layer, a very fine tissue layer that you're not really going to see in a lab. It's called endoabdominal fascia, or more commonly, it's called transversalis fascia. Transversalis fascia. Let's use that term. Transversalis fascia. And deep to that is extraperitoneal fat. There's a yellow line here. And deep to that is going to be the parietal peritoneum. So simply going through the abdominal wall, you go through all these different layers. Now tomorrow, we're going to talk about the parietal peritoneum. It's very much different than the parietal pleura, or the parietal layer of the visceral serous pericardium. It's much more complicated than that. And so we'll spend a little bit of time tomorrow morning going over that. But today, suffice it to say that if you're looking at the abdomen and you pierce the parietal layer of the parietal peritoneum, then you're going to be looking at the organs. Which is what you're going to do at the very end today. You're going to open up the abdominal wall like a cereal box top. So tomorrow we can get right into the organs and blood vessels. All right. Now the superficial fascia, this campers and scarpas, is continuous down onto, this is a male. It continues around the penis actually, and around the scrotum and into this area of the body called the perineum. So behind the scrotum, in front of the anus, is the perineum. In women folks, it's behind the vagina and in front of the anus. That's the perineum. And the similar thing happens with females. It just wraps around but it's not quite so well defined in females. It wraps around the labia majora to get into the perineum. The reason I tell you this is because if you wind up, if you're playing softball or something, or bowling, and you get hit in the abdomen, and you've got a big bruise right here, it's just like a bruise up here we talked about is going to drain down, and you're going to have a black eye. A bruise in the abdomen is going to drain downward, and you're going to wind up with a black and blue penis, scrotum, and perineum, because it's all in the same plane. Similarly, one of the worst things I ever saw was, well, I didn't actually see it, but a colleague of mine did incised and drained a perianal abscess. Remember I told you guys I never poke a hole in those things, because you never know what's underneath them? Well, he didn't know what was underneath that one either. She wound up with necrotizing fasciitis. Remember the anti-inflammatory necrotizing fasciitis? and it got in this layer, and it actually came all the way up from her anus, all the way up through her external genitalia up into her abdomen. And the only way to deal with that is to go and debride the whole area. So they had to remove all of the campers and scarpas from her umbilicus all the way down through her labia majora. It was just a horrendous nightmare. It changes its name too, from scarpus fascia to the dartos to Colles fascia. Next week when we get into the genitalia, I'll define those different areas for you. Although one of them, I think you're going to see today, the dartos. Anyway, we'll get to it later. All right, the muscles of the anterior abdominal wall. From the outside is the external abdominal oblique, like the intercostals. It's like you put your fingers in your front pockets. You get through that, and you got the internal intercostal, internal abdominal oblique. Put your fingers in your back pocket. And the deepest layer is the transversus abdominis. Does that have, oh, it says internal oblique cut. Transversus abdominis right here. Those muscles are more parallel to the ground. So external, internal, transversus abdominis. You have another couple of muscles that are there. One of them back here is actually a back muscle. Is quadratus lumborum. That's the muscle where you bent over a long time and you stand up and you do this. Oh, that's quadratus for a large part. You see a lot of spasm in that muscle because of overuse. Now anteriorly, there's another muscle here called the rectus abdominis muscle. The rectus abdominal muscle. Here's the external abdominal oblique. Here's the internal. And so the aponeurosis of these muscles, they wrap around the rectus abdominis muscles. The rectus abdominis muscles arise from the ribs and insert down here in the pubic bone area. And they started out when you were a little bitty embryo as different muscle myotones, different muscles that fused. So because of that fusion, you have essentially well, it's not really a ligament. It's muscle-to-muscle attachment. That's your six-pack. Like me and Paul and so Taylor. Yeah. So anyway, you have a sheath, a rectus sheath. So when you look at your cadaver, when you remove the skin of the cadaver, you can see the external abdominal oblique, but you can't see the rectus muscles. They're inside this sheath. Now the makeup of this sheath has to do with the tendons of the external and internal abdominal oblique and transversus abdominis. Before we get to the sheath, here are some points to know here. All of the abdominal muscles are innervated by the primary rami of thoracic spinal nerves. Why do I say thoracic spinal nerves? If you look at the dermatomes, T10 is the belly button. T12 is the pubic bone. I said that back on day one. So T12, down to T12, it supplies all of your abdominal muscles. The abdominal muscles, one of the role is to compress the abdominal contents. Mine's a lose in that battle. And then the fiber orientation is there, and it's difficult to differentiate the internal oblique from the transversus abdominis. Bottom line is if you're looking at the underside of the abdominal wall, that's transversus abdominis. That's the easiest way to do it. Okay? All right, so here's the rectus sheath. So there's an anterior sheath. See, they've cut away the anterior sheath. And they've cut away the muscle. And so now back here you have the posterior rectus sheath. So you've got an anterior rectus sheath, posterior rectus sheath on either side, and this fibrous layer that connects the two is called the linea alba. Linea alba, which is in the midline. If you look at the rectus muscle, it's not straight up and down. It actually goes out to the side. Because of that, somebody thought it looked like a half moon, so that's why they call it linea semilunaris. I will never ask you that question. But you do need to know the linea alba because it comes into play, especially in pregnancy and in types of hernia, abdominal hernias. It says down here, the contents of the rectus sheath include not only the muscles, but some superior and inferior epigastric vessels. Superior and inferior epigastric vessels. That's what we need to focus on here in a minute. All right, so let's talk about the sheath. If you look at different cross sections of the rectus abdominis, the anterior and posterior rectus sheath are made up of different structures. If you start up here and up high, and if we look at this, this is up here high, right here. There's the rectus abdominis right there. So there's the external abdominal oblique. You see the aponeurosis? It goes in front of the rectus muscle. The transversus abdominis on the, excuse me, let me go up here. This is, I've got the wrong picture. The external goes in front of it. The transversus abdominis here goes behind it. And the internal oblique splits. So half of it goes in front and half of it goes behind. See, that's easy, right? It's simple. Up here high, above the belly button, that's what it looks like. External goes in front, transversus goes behind, internal splits, half goes in front, half goes behind. So if you look up here high, whoops, if you look up here high, the anterior and posterior rectus sheath are made of the same stuff. You know, one aponeurosis and a half of the internal. Right? However, if you go down below the belly button, all three aponeuroses go in front of the rectus muscle. And the only thing going behind it is transversalis fascia, the extraperitoneal fat, and the parietal peritoneum. In other words, the aponeuroses of all three muscles go in front. So as we start up here at the top, you see the green? That's the posterior rectus sheath. Once we get down to the belly button, there is no more posterior rectus sheath because all of the aponeuroses went in front. In fact, what you have left right there is a little arched structure there. That's the bottom of the posterior rectus sheath. It's just below the belly button. That little arch is called the arcuate line. It's written up there somewhere. There it is, arcuate line, right there. The only thing the arcuate line is the place where all of the aponeuroses went in front of the rectus abdominis muscle. This illustration, this picture here illustrates it again. Above the arcuate line, you have one in front, one in back, and the internal splits. Below the arcuate line, all three go in front. The only thing behind are transversalis fascia, the extraperitoneal fat, and the parietal peritoneum. Now we're going to come back to that in just a minute. The nerves, T8 to T12 that supply this area, like the intercostals, run between the two innermost layers. So when you take so as they come out of the back, they're going to dive between the transversus thoracis the innermost intercostal, and then they're going to wrap around, and then they become cutaneous. And the two cutaneous nerves that you see quite easily are the iliohypogastric, and below it are the ilioinguinal. They both come off of L1, and where they're headed for is down here in your genitalia area. Iliohypogastric, ilioinguinal. The ilioinguinal is easiest to find, and it's really the only one that you need to worry about finding today. And I'll tell you how to find it here in just a second. The vascular supply is segmental as well to the abdominal obliques and transversus abdominis. And here's something I want to talk to you about. Remember the internal thoracic here? We kind of left it as, well, there it is right there on the underside of the chest plate. Well, how does the internal thoracic end? It divides into a few branches. One branch of the internal thoracic is called the musculophrenic. It provides the blood supply to part of the diaphragm. The other terminal branch of the internal thoracic is the superior epigastric. So the internal thoracic comes down, goes through the diaphragm, and continues down onto the anterior surface of the abdomen as the superior epigastric, between the rectus abdominis muscle and the posterior rectal sheath. Posterior rectus sheath, not rectal. Okay. Down here you have the femoral artery, because it passes under the inguinal ligament. It's that white line going from the ASIS to the pubic tubercle. Just before it dives under there, it's the external iliac. That external iliac gives off a branch called the inferior epigastric. The inferior epigastric ascends, again, between the rectus abdominis muscle and the posterior rectus sheath, and anastomoses with the superior epigastric. Yeah.
Can you say that one more time?
The inferior epigastric ascends like the superior between the rectus abdominis and the posterior rectus sheath. It will actually anastomose with the superior epigastric. So you've got a collateral blood supply of the rectus abdominis muscle. I was telling somebody yesterday, or the day before, what is today?
Wednesday.
Wednesday? Wow. That the internal thoracic artery is often taken down and used for bypass surgery. So if it's taken down, if you remove it, you got to make sure that the downstream stuff still gets a blood supply. Well, the downstream stuff of the internal thoracic is the superior epigastric, and that's just fine because you can still supply the rectus abdominis from the inferior epigastric. So that collateral blood supply is pretty handy. Now, there are other branches here, the circumflexes and things like that, superficial and deep, forget those. The artery that's important down here is the inferior epigastric. Now remember, the arcuate line? The arcuate line would be right about here. There's belly button. Would be right about there. You understand that when the inferior is going up, it has to dive between the rectus, posterior rectus sheath and the muscle by going up through the arcuate line. It has to go past the arcuate line. So down here, it's sort of free floating because there's no posterior rectus sheath. You understand what I mean? This is something I'm going to bring up more tomorrow. When you see these superficial arteries like this, superficial epigastric, superficial circumflex, there's a vein that goes with the same name. So there's some venous drainage of the body wall here. In liver disease, you can have varicosities, varicose veins associated with these superficial abdominal veins, abdominal wall veins, and it produces a condition called caput medusa, the head of Medusa. I'll explain this more tomorrow, but you can see these dilated varicose veins that from the previous slide. This has to do mostly with blockage of the liver failure due to cirrhosis, and I'll talk about that more tomorrow. All right, now we're on the inside of the abdominal wall, looking at the back side of the wall. And this is what you see. Over here on this side, the parietal peritoneum is still in place. If you remove it, this is what you see over here. There's the arcuate line. You see the arcuate line now? Does it make sense? You see where the inferior epigastric vessels dive into that posterior sheath by passing the arcuate line. Down here, they form a fold in the parietal peritoneum. That fold is called the lateral umbilical fold. The lateral umbilical fold is formed by the inferior epigastric vessels. There's a midline fold called the median umbilical fold that connects the top of the bladder with your belly button. The median. It's an embryological remnant of a structure called the urachus. I'll talk about this more tomorrow. It serves no purpose other than there it is. So if I ask you what structure gave rise to the median umbilical fold, you would say the urachus. And then between the median and the lateral umbilical fold is another fold called the medial umbilical fold. The medial umbilical fold is formed by the obliterated umbilical artery. So you have one median, two medials, and two laterals. You can see on this illustration, here's the rectus abdominis muscle right there. This would be the transversus abdominis right there. Okay? You see that right there, that little place right there? I'm going to talk about that in a minute. That little place right there is called the deep inguinal ring. If you're a guy, what goes through that deep inguinal ring is the testicular artery and vein and the vas deferens. If you're a female, the only thing that goes through there is a structure called the round ligament. Now we're on the outside, looking at the abdominal wall. Here's the external abdominal oblique right here. And there's the aponeurosis. There's it forming the anterior rectus sheath. Right there. The inferior margin of the external abdominal aponeurosis attaches at the ASIS and at the pubic tubercle. And then when it attaches there, it rolls on itself. It rolls under. So it actually, as it rolls under, right here, you see that? It makes a little canal. There's an opening in that canal right here called the superficial inguinal ring. If I take my finger and I pass it through that superficial ring on up into here, I'm going to be able to pass it through the deep ring out here. Remember, the deep ring is going inside the abdomen. This forms between the deep ring and the superficial ring, the inguinal canal. Now what we're going to do is we're going to take off the external abdominal oblique aponeurosis and open up the canal, and that's inside the canal. There's the aponeurosis. Now we're looking inside the canal. There's the deep ring up here. This is where they came through the body wall. That thing right there is the spermatic cord. The two tendons right here of the internal abdominal oblique and transversus abdominis join to form a thing called the conjoint tendon. It's the most medial part right here at the pubic tubercle. I'll explain why that's important later on. It's the internal abdominal oblique and transversus abdominis, the two deeper layers of muscle. They form the conjoint tendon. Everybody understand this deep ring, superficial ring, inguinal canal structure? You don't understand? You don't know what that is? Are you serious? Okay. So, if you and I are hanging out inside this person's abdomen, okay? And I want to get into your ball sack. This is how I'm going to do it. This is how I'm going to do it. You knew I was going to use that term? It's an anatomical term.
I knew you were going somewhere like that.
Yeah. This is how we're going to get there. We're inside the abdomen. We're going to get into the scrotum. This is how we're going to, this is how we're going to go there. We're just going to go the same route the testicle did. Your testicles started out up here, not your testicles. Your testicles, when they start out, are up here. As you develop embryologically, they get pulled down and into your scrotum. Well, how they get there is they get pulled down and they get pulled through that deep ring right there. You understand what the deep ring is? Settle down there, sheep. Okay. They get pulled through here. Here's the inguinal canal from the inside. That would be the equivalent of where the inguinal canal is. They get pulled through the deep ring, down the inguinal canal, and out the superficial ring into the scrotum. That's how the testes get there. That's how we would get there. We would just walk. Now does it make a little bit more sense? Okay, good. Anybody else lost? Okay. If we open up the inguinal canal, this is what you're going to see. That's the canal. Now in guys, the spermatic cord and the ilioinguinal ligament are in that canal. The spermatic cord and the ilioinguinal ligament come out that superficial ring. In guys, the superficial ring is pretty well developed. In females, it's there. You can find it. It's not quite as obvious, but the only thing that comes out of the superficial ring in females is the round ligament that I mentioned earlier and the ilioinguinal nerve. By the way, these fibers here, they're called medial and lateral crural, C-R-U-R-A-L. Don't write this down. You don't need to know this. Well, you might need to know it. And the ones that cross here, well, the reason I say that you might need to know it, I was originally said no, but then you probably do, is because if you have a hernia, that I'm going to explain a little bit later, the way you fix the hernia is you make this ring smaller. You suture the crural fibers together, and you suture them also to the conjoint tendon, and that way you can tighten that hole. You can decrease the diameter of the hole and prevent inguinal hernias, that we'll talk about here in a second. Anyway, these intracrural fibers here, they help the opening from unzipping. If you had all the fibers going in the same direction, they could rip apart pretty easily. If you put some across there, it's like, the end of a zipper. It won't let you go beyond the end of the zipper. You see what I mean? All right, so here we are again. Right there. And here are what vessels are these? Inferior epigastric vessels. The deep inguinal ring is lateral to the inferior epigastric vessels. The deep inguinal ring is lateral to the inferior epigastric vessels. The superficial ring would be medial to it. If you take and form an artificial triangle between the inferior epigastric vessels, the midline, or the urachus, and the inguinal ligament, that forms a triangle. That triangle is called Kessel Box Triangle. It's just an arbitrary triangle. Inguinal ligament, the medial part of it, the urachus, the inferior epigastric vessel. That's called Kessel Box Triangle. You see, Sarah?
Kind of.
So we're going to draw a line here. There's the point of the triangle. Come down to urachus, and there's the floor of the triangle, the base of it, the inguinal ligament. That's Kessel Box Triangle.
Hessel.
Understand, huh?
Hessel or Kessel?
Hessel, not Kessel, that's here. That's in your nose. Kessel Box, like with an H. It's spelled just like it sounds. There are a whole bunch of S's. There's an L and there's a B. Okay? And it doesn't go with your nose.
Not quite.
That brings up an interesting point. A long time ago, and I can tell you who this person was. She was a practicing PA. On the lab practical, I took, when we were doing if you take a cross-section of the penis, if you take a cross-section of the penis, it has 3 different parts to it. And it looks like that. A cross-section of the penis. And I took a cross-section and I put it on a lunch tray and just said, what is this? And I had a student call it, if you are to look at the carina, it looks like, if you take a trachea and cut it and set it there, it looks like that. I had this penis there, and she called it the carina. To this day, that was probably the worst answer I've ever seen in a lab practice. To call a penis a part of the trachea. What's that right there? What's that right there? That's the median.
Medial.
That's the medial. And what does the medial form from? The obliterated umbilical artery. So I named this Kessel Box Triangle, right?
Yes.
The deep ring is not within Kessel Box Triangle. The superficial ring is. Now, before I go into the inguinal hernias, if you look at these muscle layers and the aponeuroses, the fascia, and follow it into the scrotum, they actually become continuous into the scrotum. And you can follow these things. Here are the abdominal muscles here, and their aponeuroses. You can follow them into the scrotum because they form different layers of the scrotum. One thing I want you to observe, though, is you see right here, this dotted line, we are inside the abdominal cavity here. There's the parietal peritoneum there. Your testicle, remember I said got pulled down to into your scrotum. It got pulled in there by this thing right here called a gubernaculum, which is probably one of the goofiest words in all of anatomy, a gubernaculum. You know, he died last year. Gomer, and he had a brother named Goober or something on the Andy Griffith show back in the 60s, 70s. You guys don't know that? What was the guy's name? Gomer was Gomer Pyle. What was his name? Jim Nabors. Jim Nabors. Jim Nabors. The oddest thing about Jim Nabors is he was an opera singer, and he had this amazing voice. But back in the Andy Griffith show, Gomer, his cousin, his name was Goober. So every time I see gubernaculum, I think, because that show was filmed in North Carolina, which is where I'm from, and so I grew up in a place like Mayberry. So it's kind of like going home. Every time I give this lecture. But anyway, got sidetracked a little bit. You understand, though, if this thing gets pulled down into the scrotum, there is the potential to go back up through there. Right? Now, this ordinarily is going to close off, and you won't have a communication between the peritoneal cavity and the scrotum, but you could. Right? You could. And I'll show you in a little bit why you can. And the only other thing there are two other things I want you to see on this slide here. One of them is, so here's the peritoneal cavity. As the testis is being drawn out through there, it takes a piece of peritoneum with it. And that piece of peritoneum essentially forms a little, like a bursa, a little sac. Has a very small amount of fluid in it, and is in front of the testes. That little sac made up of peritoneum that got pulled down there with it is called the tunica vaginalis. The tunica vaginalis. Very small. You can't feel it on yourself or on the patient. It's in the front of the testicle, because in the back of the testicle is where the epididymis is. We're going to do testicles more when we get to the next block. But since this is related to the inguinal canal, that's why we're going over today. The other thing that's important here is the aponeurosis of the internal abdominal oblique down here in the scrotum is called the premasteric fascia and muscle. You could just call it the premaster muscle. The premaster muscle. So you know that the scrotum, the testicles hang down. And if you get cold, they're drawn back up to the body for the warmth of the body. If you're too hot, they go back down. They move. That's the Premaster muscle that raises and lowers the testicle. Amanda, you look perplexed again. You're following me here?
Yeah.
Okay, so this is what I want you to do. Y'all get Ryan, Paul, Zach, who else am I missing here? Fawn. Gonna take a lot of alcohol. So what are you gonna do? This is actually, you know how you do if you're sitting here, I tap your patella, you have a patella reflex. Okay? You also have a Premaster reflex. The Premaster muscle is innervated by a nerve we're going to see tomorrow called the genitofemoral. It also comes out of that L1, L2 area. If you have a spinal cord injury, I want to know what level nerves work and don't work. And so you test the patellar reflex and you test the Premaster reflex. Any of you guys working in the ER, you may have seen it happen, may have seen people do it. Now this is not a reflex like the patella, you know, that's brisk. This is a cutaneous reflex. So what you want to do with these guys is have them stand there with their scrotum hanging down. And you take a pencil, and this is their legs right here. Take the pencil, and on the inside of their thigh, up here high, rub it like that. I mean, you got to rub it pretty good. I mean, rub it like if this is the inside of the thigh. You want to rub it. You want to put it on there pretty firmly, and you want to rub it pretty hard, like that, right? And just wait, because it takes a couple of seconds before the reflex acts. The testicle on that side will lift up slowly and go back down. That's called the Premaster reflex. You can also do it with them lying down. Stroke the inside of the thigh, and the testicle will go up and go back down. So that's how you know that the spinal cord is intact at that level. If you have a husband at home, or a male, or somebody you found in a bar, I don't care what it is, test that Premaster reflex. It works pretty well. I think there actually is a similar, if you do it to females, what happens is their belly button will, their abdominal muscles will contract, and the belly button will kind of point to that side. It will. I've done it. That's actually a, you don't believe me. Y'all open your mouth. You're going to pay for it. Lie down. Get up there, lie down. We're not going to Premaster you. That would be. What's that doctor's name with the gymnastics?
Larry.
Is that crazy or what?
Yeah, very crazy.
Okay. What's the next thing? Okay. Can we look at your belly? All right, now. Oh. Here. No, not you. All right. So you also have reflex.
You can't see
It's
anything.
the umbilical reflex. That's the abdominal muscles. These guys back here, they know I'm not doing something weird, right?
Right.
So you know that the belly button is T10. T10, right? So this is 8, 9, 10, 11, 12. So if we're looking to see if her spinal cord is intact, we're going to do the cutaneous abdominal reflexes. Now what I'm going to do is just relax. All I'm going to do is take this pen and do like that on your abdomen, okay? All right, watch your belly button. You're not a good one. Come on up here. You gotta have some people have brisk reflexes, some people not so much so. You gotta have somebody.
Oh.
Yeah. We're gonna get it, we're gonna find it, you're gonna see what I'm talking about. Okay, can we look at your belly button? Just relax. Look at a good rectus muscle. Look at a rectus muscle. Right here.
Dang.
Yeah.
Girl, showing off.
You had your belly button pierced. So that's the first thing you do when you examine the abdomen is you inspect the abdomen. And so if I'm writing up or typing up my physical exam here, I'm going to note that. Patient had a piercing of the umbilicus without hardware. So that's something to note. Y'all see that? Okay, just relax. You're good. You can pull your shirt up just a little bit. See, if you go that way, it's T11, 12. If you go that way, it's T8, 9. That is amazing. That is amazing. I've never had anybody contract their biceps. So that's the type of thing you'll see on the premaster reflex, except it's slower, much slower. But the premaster and the umbilical reflexes are what are called cutaneous reflexes. Your patella, your biceps, your triceps, your Achilles, they're called deep tendon reflexes. Okay? I have somebody's pen here. Okay? Okay. Here is the, one more slide here and we'll take a break. So here's the superficial ring right here. The spermatic cord exits the superficial ring. There's the ilioinguinal nerve. You'll find the testicular artery in here. That's a little red thing. It's really kind of small. You'll find the hard cord-like vas deferens when you open up the spermatic cord. And instead of a specific testicular vein, you have a network of veins called the pampiniform plexus of veins. And what this pampiniform plexus does is you've got this hot blood in the artery going into the testicle. So what you want to do is put all of these low temperature veins around it. It's a heat transfer. The pampiniform plexus is essentially a heat transfer. So you see the spermatic cord going up into the inguinal canal through the superficial ring. Go ahead and take a break and then we'll come back.
Probably you can get there.
Everything, and then like we like did like tests on them, like we put them in like cooler, and like really cool room, be real good, and then we would like test there. It's really cool. And it literally is like Premaster, it like pulls your ball up.
Stinky balls?
Yes.
I
like it. I just want to have it right.
Yeah, okay, I know. And honestly, it's pretty easy to try, but I haven't tried it.
Yeah.
Once we get to classes where I'm gonna type,
Yeah.
I'm only writing for an hour. In class at least.
Hernia, Inguinal Hernia. And I literally had to do this. I knew what they were doing. I had like, if I would type it really
It's tragic.
And it used to hurt, and so I got like all these tests done, and they had when you don't know what it is.
I know I typed that.
I don't know, it's bad.
Like when you're like scroll through.
It bothered me like one time, and I couldn't figure out what it was. I didn't know if I had to an atlas hole or if it was this. Every time I'd like, it hurt like really bad. But now I don't know what it is.
You know that guy got.
I like a tumor.
He got life?
Yeah.
Well, didn't he like sexually abuse it?
What is it, poking to the, 42. Because he was messing with like me. He was, I didn't know he was shrinking.
I don't know. I mean, you have a hernia or have 40? I don't know, because I thought that too. I don't know.
They told me what they were doing. They were
And you
just
get
like,
that's just really
So this is.
more like pregnant.
I had
It's really good. And that's when which prevented
I don't know if it's big old bulges.
I swear I think it was on formulating.
I can feel it.
It was like a few years long and it was